All right, it's the end of the day. We'll get started so we don't keep you late. Good afternoon. I'm Mark Olaf from the Geisinger Commonwealth School of Medicine. There's half of the audience is people that I brought with me, so that's great. I'm a regional associate dean. We have a 6-campus model, so our flagship hospital in the center of the state is my regional campus, and I'm also the vice chair for emergency medicine education at our medical school. So we're going to talk about billable student notes and what that means for our students and what our experience has been in developing this model and implementing it, and a couple of preliminary results. So I want to share with you some of the strategies that we use to implement this. And then hopefully what you take away from it is you understand some of the regulatory components that this can actually help you with and how to overcome the regulatory hurdles. I'm going to talk about where the barriers were, where those hurdles were, and then hopefully you can maybe be the champion at your institution to create and implement this with some of the stuff we'll talk about. So first of all, why do we do this? Why take this on? So there's a couple of reasons, and I already mentioned kind of the regulatory aspect of that, and I'll get to it in a second. But for me, the biggest why is really that students learn from this experience. So there's the concept of documentation, and this is a paper from Advances in Health Science Education from last year, and they kind of reframe the concept of documentation into this concept of composing. And so these folks did a qualitative study. They looked at 110 hours of observing junior trainees and senior internal medicine residents, and basically just watched them take histories, watched them write the notes. They watched them they watched them do the behaviors that we've all experienced and we've all participated in, where you're in the room, you take the history, you think you're done, you're still a med student, so you walk back, you start to write your note, and you realize, I didn't do my neuro exam, and I go back in and do it again, and they wrote about this. So they kind of presented that as this concept of students aren't just writing a note, they're not just thinking about what goes in the HPI and the review systems, and those are parts of it, right? They're learning to be part of the healthcare system, but they're learning how to integrate the concepts, and that's where the note comes in to kind of say, well, this is how I'm thinking about the problems, this is how I'm developing my ability to do medical decision making. So if we think about implementing this and billable notes as a way to teach this concept of composing or allow our students to participate in composing, it becomes a really fundamental and really important way for them to think about how they take care of patients. So for me, that's the biggest why. And this is one of the conclusions from this paper, and really it's just the part at the bottom there, composing, which captures the more complex interaction observed between writing and thinking. It's the thinking part, not just the writing part, that our students really get a lot out of this. So for that reason, the note is a very target-rich environment. There's lots of stuff that we can teach our students and help them develop, not just teach them, but allow them to develop in themselves that comes out of this experience. Then there's the regulatory piece. So EPA number 5 says a student should be able to write a note. So kind of say, we're not absolutely beholden to the EPAs, but there's certainly a good framework for what we should be able to have our students do by the time they graduate. So this is one example at the UME level, but even at the GME level, the ACGME, here's our ABEM milestones, and systems-based practice number 4, write an efficient integration of information and technology. So this is something that ideally a resident can do, not that a student can't do it, but this is kind of plastered throughout the expectations for our learners is kind of the point. So people have written about this before. People have looked at what these barriers are, and this paper from 2016, which I've referenced in talks before, kind of points out a few areas where we see these hurdles and why people aren't doing this, or just not having students write notes at all. So I'd point you to a couple of these. So they surveyed about 100 clerkships, give or take. 95% of them had some version of reviewing notes for feedback. Fewer than half of the notes reviewed, so less than 50% of notes were reviewed in 70% of clerkships. So very few notes getting reviewed. Half to 3/4 of the notes were reviewed of the ones that students wrote, 23% of clerkships. And looking at basically all or most of the notes that students wrote only happened in 7 clerkships. So students are doing the work, but without feedback. And if we don't give them feedback, then we're either not reinforcing habits, not teaching them, or we're reinforcing perhaps not so great habits, and we're not reinforcing perhaps good habits that are there. We're just not giving the feedback. Oral and written feedback were given in only 25%, and documentation was considered in the final grade in 58%. So we're counting it for a grade, but also not necessarily giving them feedback for development. So this also raises kind of the challenge of if we value this, and if the EPAs and the milestones are telling us we should do this, and we're incorporating into our grading scheme, but we're not actually developing the skill, we're kind of missing the point here. So it's another reason to kind of pay attention to this and implement it. So why do this now? Well, in 2018, CMS changed the rules, and they said we can do this. We can have students write notes, just like our ancestors, our forefathers and foremothers in medicine used to be able to do when things were handwritten. But they said you can't just have them do it. The student can't just be the scribe. There's some very clear language around that. But the attending still must verify in the medical record all student documentation or findings, including history, exam, medical decision-making, and the physician must personally perform or re-perform the exam and medical decision-makings of the E&M service being billed. So I put this in here to highlight this isn't like the supervision that we often give our residents, where as long as the outcome is what we expect it to be, and as long as we're providing the guidance and the oversight that we feel is necessary for that patient, we don't have to do all the same things the resident's doing. For the students, we explicitly have to do all the stuff that we document. Now, it doesn't mean if my student checks the ocular motion on the ankle sprain, I don't have to go check that. I just don't want to document that I did, right? So that's the only difference. There are a couple of myths around this, and one of the big myths that has been pointed out is that seems to be a barrier to this implementation is that teaching physicians are required to redocument everything that they wrote, and that's not true. You don't have to go back and write it. It kind of defeats the purpose of this. Whatever the student documents, you can edit. The re-perform is the physical presence being in the room. Now, different institutions have explored this and done it in different ways. There's a bunch of ways that it can be done, but there's a great article in Academic Medicine that was written about 2 years ago about how this worked at Duke University. And so our project here was to kind of add to this kind of growing body of literature. There's not a lot out there about this, so it's maybe an opportunity for some scholarship and to advance medical student education. But there's a little bit out there, and Duke pretty successfully did that. So we used a little bit of that model, and when we started doing this, we looked kind of surveys literature and said what is out there. And so we derived our model from some other experiences. We also, as we launched this, conveniently, we actually had a new dean come to our medical school, and she had previously been at the University of North Carolina, where they had also implemented this. So she brought with her a set of knowledge and experience with this, and helped us to implement this and be a champion for it. So what did we do as we started to implement this? We got together a core group of people, and this probably just represents the core group of important decision makers who really kind of had the oversight here. So we needed folks like our system CMO, we needed the dean, we needed folks in charge of graduate medical education, because this was going to somehow influence or alter resident workflows. We needed folks from the UME side, so our vice dean there. We needed folks from billing and coding, because we're going to alter something and kind of change their workflow as well. Regulatory and compliance, that was they had to be at the table, because this was going to change their workflow as well. Legal, that was very eye-opening to kind of see how lawyers look at what we do, and when we're kind of trying to push, we're not really pushing the envelope by any means, but we're trying to push the envelope from an institutional standpoint and do something new. And then we wanted to have some of our clerkship directors there, because they were the ones that needed to they wanted to get the information from the feedback to inform end of rotation evaluations and student assessments and things like that, and we needed to have their perspective. So this is mostly the people that were had a seat at the table, and we brought more people on as this thing rolled out. I wanted to consider a number of different factors. So you can see the people listed there that were kind of our primary focus on what we were going to alter. We were going to alter a workflow for all these people. And so we looked at outcomes and what was going to determine whether this was successful or not. We had to look at a couple of things. One, we wanted to look at satisfaction. Did this make the experience better for the attendings, for the residents, for the students? Did it seem to improve anything? The other thing we thought that there might be an influence, although we suspected it would be essentially overall neutral, but time. Did this cost people time? Did it open up time? Did it create a shift in time, meaning something that I used to do, I had to do less of, so then I had more time to teach maybe? And then, of course, money, right? This was the big institutional question of, is this going to cost us some money? And we have a couple of our students who experienced this here in the room with us. They, a couple of their, none of these guys, but a couple of their classmates even came forward and said, are you going to use me as a scribe? Am I going to pay you tuition to do work for you? And the answer was no, of course, that this is all above water, but it helped highlight and reframe for me how we were sharing this with students and what actually this was going to bring to the table for them and how it was going to enhance their education. So we'll talk about that in a minute. So data that we wanted to capture, we wanted a lot of student-centered data. We wanted to see, were they more satisfied doing this, and look at course evaluations, some version of student assessments. Did those change in any way? We wanted to look at overall student growth, or can we measure that? System-centered or physician-centered metrics, physician satisfaction, coding and revenue, documentation integrity. We have a process that a whole set of, it's separate from billing and coding, but we have a set of folks that work with our electronic health record, which is Epic at our institution. That actually sends messages to folks on the inpatient side, and they'll say like, oh, yeah, I see that you have, your patient is obese, but you don't have the right CPT code for the right kind of obesity, and they'll ask a clarifying question and say, could you put this in the note? And that happens. We wanted to know if that process was going to be influenced at all, if it was going to be altered or changed. So we had there's a lot of pieces here that we're still collecting data on, and I can't tell you about all of these things today, but this is where we started off kind of thinking about what we wanted to capture. So what did we do? How did we do this? There's a couple of workflows that you can manage this way. The one workflow that would not include residents at all would be for the student to write the note gets sent to the attending co-signs it, edits it, and then it gets sent to the billers and coders. This is analogous to the usual resident workflow, right? They write the note, gets sent to the attending, edited, billing and coding. Another option is for the student to write it, send it to the resident, the attending, billing, coding. Both of these are viable. There's no right or wrong answer, although initially at our institution, a couple of folks in compliance felt very strongly there was a right answer, and it included not involving the residents. So we said, okay, we'll start there. So that's where our proof of concept was starting with student to attending and kind of excluding the residents from this. The nice thing that option afforded us was when the students were on resident teams, it meant that our implementation was such that we would actually free up the resident from writing a note or two, whether that was in the emergency department or whether it was on internal medicine and other places in the organization. And that resident was now not responsible for writing the notes, but responsible for reading the note, helping the student edit it, and giving the student feedback so that by the time it went to the attending, it was a resident level note, the student had got taught, but the resident was saved the time of writing 2 notes or so. So it was a bit of a trade-off. That was where that time shift comes in a way that we still had residents included in patient care, but brought the students in more fully. So we planned, we did, we're studying, and we're hoping to act on some of that. So let me share with you just a couple of preliminary results. This is kind of fresh off the presses, not really even complete because we're not even through the academic year where we fully started this. But we did a pilot last year in emergency medicine, and the dates here can be a little bit, I'll try to walk you through it because there's 2 different set of dates, but it's not terribly consequential. As we tried to look at this, we implemented this last summer, and what we wanted to look at for course evaluations was we did our pilot, and then we kind of ripped the Band-Aid off and let students kind of do it everywhere. So in the pilot part, we had certain places where students were doing this, and then other places where they were not. Overall, at note writing sites, the billable note writing sites, you can see the numbers are marginally better, but they're not significantly different. They're not that different from the all sites average. So the overall way that students view the entire course, which is admittedly a very, very robust measure of or not a very specific or granular measure of the note writing experience itself. And then faculty feedback rating, again, lots of other pieces that go into that, not just the note writing part, but there weren't any substantial differences there. When we expanded this, we also didn't really see any significant differences either. So basically didn't really overall affect the courses from the perception of the students. Now the real question that everybody else in the institution was worried about was, is this going to cost us any money? So these are our ED billing levels, and you can see when we started, before we even did any pilots in 2022, and we wanted to exclude 2023 data from this because of billing and coding changes, it'd be a little bit a confounding effect. So just looking at 2022, there were no significant changes in the levels of billing or the total revenues, which is the next one here, or the one following this. This is the clinical documentation integrity team, so how many inquiries they do about like how good your note was. They don't do this for EM, but they do this across the system, but this is just to kind of show there really wasn't a change. You see like a little bit of that October, November, December kind of like bumping up, but if you average those numbers, there was no significant difference in the amount of work that people had to do to revise these notes. These are denial amounts. So January there, a bit of an outlier, but you can see because the student was writing a note, we didn't move the needle one direction or the other in terms of denials for billing. And then in terms of average days to post payment, this didn't change either. So it wasn't like people were scrutinizing this harder and saying we were more skeptical and you got to do more work to prove that this was worthy or anything like that. So overall, we're not seeing a whole lot of needles move anywhere, which is kind of the point here, right? We didn't think we were going to make money by doing this. We didn't think we were going to save time. We hoped that it improved the experience, and we hoped that it was essentially neutral for those things. So that was good. But where we really did see some of this, and part of the overall analysis will end up being a qualitative approach to this or a mixed methods, because this is where a lot of the, for me, a lot of the satisfaction comes in. So this is student feedback. So residents were always willing to read through student notes on teaching shifts, provide feedback for improvement. Direct and immediate feedback on each shift was helpful to make progress on each subsequent shift. So this is, they just got more teaching. They're getting extra teaching because they're doing this. When I was writing billable notes, residents proofread them multiple times before sending the attending. So there's also kind of a comfort level for some students too as I'm doing this. Hey, I have like a near peer who's going to help me do this and going to get me to a level, and then I'm going to feel better about doing that. And then as the attending in the room, that's also really nice to have, right? So that's a plus for everybody, I think. I had real-time feedback on my notes as well as suggestions to notes after someone reviewed them. Residents provided great immediate feedback on my notes during, these are our teaching shifts. Dr. Spinozzi also provided feedback by email, so we did 2 different ways to do this and offered great insight into how my physical exam documentation, my MDM, right, which is what we really hope that they get out of this. So overall, the student feedback was very, very positive. We had, some initial, I think, appropriate and healthy skepticism, but overall the feedback was good. The other anecdotal feedback that came from the pilot that we did on this with some internal medicine colleagues was that students would tell us, I learned more because I was accountable for more. And that's where the meaningful role came in for me. I felt like I was a more fully involved member of the team. I was no longer this accessory appendage that just kind of got brought along because I have to show up for my clerkship. It was, I'm now responsible for writing like something as simple as like what the saline is running at. I'm responsible for knowing whether we stopped a medicine or started one, because I'm going to write that. I'm going to write about what the consultant said, so I have to make sure I review that note or I talk with the consultant. So students in general just felt like they were more ingrained in this. And so we have a lot more analysis to do to kind of qualify that a little bit better or quantify it. In our third year clerkships, where we also implemented this, we have an actual question on the course eval that's asked specifically about your documentation feedback. And an early kind of like peek at that data shows that we used to probably get like around a 3 or a 3.5 out of 5 on the rating before we implemented this. And it's probably much closer to a 5 now. Again, just like a very 30,000 foot kind of view. So we're really looking forward to some of that feedback. So maybe I'll be able to come back next year and share with you some more detail about this kind of stuff. But that's how we did it. It seems to have gone really well. It seems like the feedback's been good. I didn't pay any of the students to come here and sit here today, so if you guys have questions, they can be the honest truth tellers about this, although not all of them have participated in this because they've been on different campuses, and not all of our campuses have implemented this. But I'm happy to take any questions. I included a little QR there if you're interested in references. There's some literature that I used to build this, and the reason I did put it this way for you is because if you're interested in implementing this, some of the literature could help convince some of the people that were on that list before that you probably need to convince to implement this. So happy to take any questions, and thanks.